Good afternoon, everyone. Welcome to AAST Grand Rounds. I'm Deborah Kuhls, and I'm from Las Vegas, and I will be the moderator for this session. And today we're going to talk about pediatric perspectives for mass casualty preparedness. And we have two speakers who are really experts, both nationally and internationally. And I'm going to first give a few words about Dr. Christopher Newton. He's professor of surgery at UCSF, and he's the former trauma medical director and current department chair of pediatric surgery at UCSF Benioff's Children's Hospital in Oakland. He currently serves as chair of the AAST Pediatrics Committee. He's a PI on 2 federal grants that I'll talk about in his disclosures, and we're very honored to have him join us today. And our second speaker is Dr. Mary Fallat, and she's professor of surgery at the University of Louisville and an attending surgeon at Norton's Children's Hospital, where she has served in practice for over 35 years. She is the former surgeon-in-chief of that institution. She has had many leadership positions in pediatric surgery with multiple organizations in her past. And she is going to also talk to us about pediatric readiness. I'm going to go on to their disclosures. And both of our speakers are grant supported by HRSA and by ASPR, and I'll let you read the rest of their disclosures. And it's important to remember that the contents are solely the responsibility of the authors and do not necessarily represent the official views of ASPR, HRSA, or the Department of Health and Human Services. And I'd like to remind everyone who's listening that we have a Q&A tool button that you can put questions in as we go through both of the talks today. If I could have the next slide, please. And what I'm going to do is just talk a little bit about the learning objectives, and everyone at the end of this great talk should be able to understand the necessary reach of pediatric readiness for adequate national pediatric disaster preparedness, and also to describe the current landscape of children's interests in burn and trauma disaster planning. Also, learners should be able to describe the state partnerships that can integrate children's interests into disaster planning and development, and to describe the pediatric challenges for a facility as they approach a mass casualty plan. And without further ado, I'm going to turn this over to Dr. Fallat, and thank you again for joining us.
Can everyone hear me okay? Yes, okay. So hello, everyone, and welcome. This talk is a little ambitious, so I will go through some of the slides quickly, but I hope if you have unanswered questions, you'll put them in the chat. Many of you are just becoming aware of what pediatric readiness is. But basically, if you aren't ready to take care of a child every day, you're not going to be ready to take care of a child in a disaster. So pediatric readiness is really a stretch goal to ensure that every EMS agency and emergency department in our country has what it takes to take care of a really sick or a really injured child. And it is a stretch goal. There's plenty of research now that provides evidence that pediatric readiness decreases all-cause pediatric mortality, including trauma. However, the pediatric ready score must be around 93 to achieve a mortality reduction. So what is pediatric readiness? The program actually started about 20 years ago, but it's pretty new to trauma surgeons. It is a scoring system based on those buckets that you see on the right side of the slide. A perfect score is 100. However, on 2 consecutive decade apart surveys of hospitals in this country, the national average is 70 and it hasn't moved. And so therein lies the impediment, actually, because if you have 5,200 acute care hospitals in the country with emergency departments open for business, and only half of them are trauma centers, then even our reach into the trauma community is not going to solve the problem. The program was introduced to the standards of the optimal care of the injured patient in 2022. So some verified trauma centers are only now recognizing the need to satisfy this standard, but it basically is a fairly low bar at this point. The emergency department has to have done the checklist. You have to understand what your gaps are, and there must be an approach to the gaps. And to be clear, surgeons don't live and work in the emergency department. They're all over the hospital. They're most of the time in surgery or the critical care unit. And so the readiness score is really going to be done by your emergency department, but surgeons have to be incorporated as part of the team and be embraced and be recognized as an essential part of that team. When you look at HRSA, because you heard that I was funded by HRSA as well as Chris, there's 3 main programs. One is Emergency Medical Services for Children, which is a grant in every state in the country. And although the law was passed in 1984, we really didn't have block grants for every state until about 2001. In 2016, there was introduction of the EMSC Innovation and Improvement Center. And this is where the research is examined, the evidence is then translated into good practice for children and promulgated across the country. And the Pediatric Pandemic Network, which started in 2021, collaborates with children's hospitals across the country as well as their communities to provide the best possible care to children in emergencies, disasters, and pandemics. And to be clear, all of these organizations, grants, are very interested in pediatric readiness and making sure that's promulgated across the country. And it's sets it into more perspective when you look at a simplistic view of the executive branch of the United States. And so here's DHHS, been in the news a lot lately. Kennedy is currently at the helm. But down this pathway is the Office of the Assistant Secretary for Preparedness and Response, better known as ASPR. And this is where all of the ASPR Centers of Excellence for Disaster Preparedness for Children lie, and Chris is going to talk about those. And here's all the HRSA programs you just heard about. And then over here is FEMA. And so FEMA is separate and distinct. That's the Disaster Response Unit. I'd say that the Centers of Excellence through ASPR and HRSA programs are really tied at the hip because we coordinate our efforts together. And this puts that into a timeline. So here's where the EMS program was authorized, 1984. Partnership grants actually started in 1997, but we didn't have one for every state until the early 2000s. Here's the launch of the National Pediatric Readiness Project. Here's the EIIC, and then here are the ASPR Centers of Excellence, of which there are now 3, and then the Pediatric Pandemic Network. So all of these are working together to create pediatric readiness and disaster preparedness for children. And there are 13 hub hospitals working on a hub and spoke model. And this map shows you where the hospitals are, but what it also does is it shows you where the COEs are. So regionally, here's Rapham, which is where Dr. Newton works. That's the western states. And if you think about where we have the most forest fires, that's the region of the country where that type of effort is most needed. Here's the Gulf 7. That's where we see a lot of hurricanes. And then up here is the Great Lakes ASPR network. So the PPN is responsible for all of the things that you see on this slide and has developed a number of toolkits, resources that are available on its website. And I'm going to call your attention to this one, Medical Operations Communication Center, because the COT has made this one of its big strategies and pushes for the next few years. And we'll be talking about that a little bit more. The PPN focus during last year was infectious diseases, mental health, emergency and disaster management, health equity, and community engagement. In particular, when the RFP was put out for this grant, we had just finished a pandemic. And so that was high on everybody's minds, but the current funded grant had the wherewithal to recognize that there are multiple hazards that could affect this country, including trauma and burns. And so fortunately, there's a trauma and burn domain within the PPN, so we're included. And this is a really essential part of the network also is thinking about the mental and behavioral health needs of children. And I will remind you that there's also in the standards for verification, one for some type of resource for determining risk for PTSD. And that particular standard has no references and no prototype in the standard that's in our optimal resources book, but we have developed several within the PPN network. So those resources are available to you. There's also new priority areas for this year: evacuation, pediatric patient tracking, and reunification, which is important if a child gets separated from their parents. Surge capacity, which we will talk about again as part of the MOCC, and then triage, infection control, and decontamination. There are over 100 children's hospitals that have completed a disaster networking collaborative. And you can see all of the different things that was focused on, but now there's a disaster response collaborative that started in 2024. There are more than 125 registered children's hospitals, which will become the hubs for the spokes of the future. And they are going through a learning process, which is on the website. There are key people in each children's hospitals who are doing modules in scheduled fashion, basically to become a disaster response institution. And then they will promulgate that to their spokes. The other thing that the PPN has done is develop pediatric exercises. For example, in Kentucky, we did a tabletop exercise with our ASPR HPP regions. And it was a tornado that struck a school within each region. And we looked specifically at the gaps and opportunities for children to make sure that children are integrated into the emergency plans of all of our state regions. If you go to the PPN network website, you'll see this banner for measles, which is high on everybody's list right now. But if you watch that banner for a minute, it will change to wildfire smoke resources. If you click on learn more, you'll go to some burn resources for children, including a buddy badge that could actually be printed and put on somebody's badge that will help with key concepts for taking care of a pediatric burn. And then, if you go to this down here, search resources, you can find a landing site for pediatric trauma resources. And there's a filter over here on the left that allows you to drill down to different things within there, including buckets of focus area, emergency management, audience format. And then over here, it'll tell you whether it's a module, an article, or a lecture. All of those are available to you if you click on there. If you go to a specific article and it's open access, if you click on this, you can actually download the article. But if you open this resource, it also gives you a little bit of information about it. So it's a great resource for you if you have an interest in disaster planning. And if you have an interest in understanding who the hub hospital is in your region, if you notify either Chris or I, we can help you find that person. With respect to burn care, I just wanted to go through about 4 slides, and many of you will not be involved in burn care in your careers, but some of you will. And I just wanted to point out that this is an area of opportunity also. So there are verified burn centers in the country. Not all of them take care of children. Many of our children's hospitals do take care of children with smaller burns, but those facilities are not really on the dashboard. And so that's a gap, especially during a disaster. There's also a diminishing workforce in burn care. If you were in a surgical residency program where you did not have a burn rotation, which is no longer required, you might have gone through 5 years of surgery residency without taking care of a burn patient. So then you never have the exposure that might attract you to that particular profession. And there's also a loss of bidirectional education and communication with the established burn community because the verification process is in the American Burn Association as it moved out of the COT years ago. So unless you have a vested interest in burns, you're probably not a member and you're not going to their meetings. So for children's care, we were able through the network to fund a meeting last year where we developed a task force and brought together 40 burn experts for sort of a think tank meeting to try to address these gaps and opportunities and think about how we might approach them. And we developed small work groups that are meeting now, and we're going to be able to have a second meeting in July. And, you know, again, I think this is an area of importance as you consider that there aren't many people who qualify as pediatric burn surgeons, and many of those who are older are getting ready to retire, and there's not much of a succession plan. So the middle part of this is just talking about if you live in a state, how would you approach integrating pediatric emergency response into your state planning? So I live in Kentucky. It's primarily a rural state. We have tornadoes here. We have a few forest fires every year. We have terrible floods in Appalachia because of strip mining and deforestation and no replacement of the trees. And now we have a climate that's changing, more moisture in the air, and when it rains, it floods. And so we've had several natural disasters in our state. And as somebody who's now interested in disaster planning, I started to try to recognize the importance of that within the context of where I live. So within your own state, the things that you can do are look at the number of counties. For example, half of ours are in Appalachia, where it's pretty poor, and that's where all the mountains are and where the flood hazard is. We are bordered by seven different states, and a quarter of our population lives in about half of the counties. We have a population of 4.5 million. We only have 2 children's hospitals. Only a quarter of our population has a degree in higher education. Some don't have internet access, and about 15% live in poverty. So if you talk about people without internet access, that also means that they have limited ability to do telehealth or have a visit with you that way. This is our trauma system. It's voluntary. We have no money. I'm proud that several hospitals have stepped up to the plate and decided that they will be trauma centers, but we have only level 1 facilities in Jefferson County, which is where the University of Louisville is, and Fayette County, which is where the University of Kentucky is. And you can see they're pretty close together. So there's a lot of our state that isn't served by trauma centers, yet disasters don't always involve trauma, but most involve children, and a functional trauma system helps. So on this slide, I sort of show you where the disasters occurred. So this is where all of the tornadoes hit in 2021. This is where we've had all of the floods, and then the red circle is, red circle's forest fires, and the yellow, red circle is flood, and the yellow is forest fires. So you can see that a lot of the state has been hit with various and sundry disasters, and where the trauma centers are important in terms of where children might get transported. But to be clear, Vanderbilt's sort of down here, so they get some of our patients. Evansville, Indiana's up here, Cincinnati's up here, West Virginia's over here. And so all of our population can bleed into other states where they might receive their care. And when you look at access to care, whether it's children's or adults, and do an environmental scan, you look at where they're cared for every day, pediatric readiness, referral patterns, geography, insurance plans, workforce. How many surgeons are there? Where's the primary care? Is the primary care provided by APPs or by family practice and pediatricians? Weather and climate concerns, transportation, including EMS staffing. What are your ambulance systems like? How many are still BLS? How many are volunteer? And then there are certainly other chapters in your state of organizations that can be helpful in terms of planning. And don't forget that the community is important, that the patient has to take some responsibility for their own health and preparedness. And how are you going to teach and educate them about that? And so once again, here is Kentucky, 2 children's hospitals. The University of Kentucky serves about half the state. We serve the other half of the state in southern Indiana. That's a lot of kids that have to travel to us, and some of them don't have the means to do that expeditiously. They have broken down cars. We have single moms with lots of kids who also have a job to support the family. So lots of considerations. So we put together a pediatric planning committee. They're listed here. I'm not going to go through all of the individuals from organizations that we solicited, but we come together quarterly. We have an agenda, and we are trying to address all of the different issues that come to bear for children and make sure that they are well integrated into our planning, our scenarios, our drills, that hospitals that primarily take care of adults have a pediatric plan, and that our regions are also capable of understanding where children will go during a disaster. When you look at a state, there are healthcare coalitions that are funded by ASPR. ASPR sends money to each state, and these hospital preparedness program regions get together and look at emergency planning quite regularly. And if you do have a disaster, then there's something called the ESF-8 that springs into action. And this is what engages FEMA, which then intersects with all of those different organizations in your state that are sending people to a central location so that they can help with where patient flow will go, load balancing, integrating with the ambulance services, et cetera. So if you look at this map, you see our 8 HPP regions. This is where we integrated our tabletop scenario, so that each region met in a central location while we did our scenario. And then if there is a disaster, there's a call map for all these people so that the lead people come together in Frankfurt, which is our capital, in a communication center so that they can help to organize all of the functions that I spoke about before. And that, in essence, is sort of like a regional medical operations communication center. And the COT, once again, is using what they developed, the National Trauma and Emergency Preparedness System Plan, which is now in version 2 and was led by Kristen Staudenmeier at Stanford, to look at how we would come together as a country if we had a disaster that involved a military civilian effort. And there are prototypes of regional medical operations coordinating centers across the country that don't just operate during disasters. They are there working every day. I'm going to talk about a few of them. But basically, an RMOC creates situational awareness for patient distribution in the local system. It might not just be trauma, it might be trauma and stroke and cardiac if it's really encompassing all types of patients, although the COT is obviously focused mainly on trauma patients and what might happen if there was a military disaster, either abroad or here in this country. It's a scaler for load balancing. What does that mean? That means that the patients in a hospital that's full who are low acuity could potentially be moved to a hospital that is capable of caring for them to make room for the patients who are sicker or have more injuries. And it's an integrator of response across public health, emergency management, what we call the National Disaster Medical System, and the military health system. There's a lot of acronyms on this slide, but I think the takeaway point here is that we have NTEPS, which is a plan for trauma and how that would need to be activated. We have the RMOC concept, which is sort of like the unit of action for a national trauma and emergency preparedness system. And then we're developing toolkits and plans for military civilian integration. And scalable efforts look something like this. You have local day-to-day operations, but then when something happens, you have a regional mass casualty incident that enables people to come together and work together to try to manage that. And if there are multiple regions, so a hurricane, earthquake, et cetera, that's sort of like the what Chris it has in his conceptual model, which is a center of excellence for disaster planning that encompasses many states, like forest fires, hurricanes. And then this is now coming to bear as something we want to do nationally so that we'll be more prepared. And the individual RMOCs would have their own strategies, including how they relate to EMS, helicopter, ambulance, injury prevention, education and training, best practices, and data and performance improvement. So all of these things that are part of a good trauma organization. So in Kentucky, we've developed a work group of key state officials. We're updating our pediatric annex to the state disaster plan. We're developing a dashboard that would work every day for available pediatric beds. We've developed a system for patient tracking. We're working with the COT to introduce the MOC concept to the state. And we're including key players from stroke and cardiac in every hospital system to just make sure that nobody's left out and everybody can be a key player because you don't know what kind of event is going to happen. And we're integrating children into this state planning as it's developing rather than as an afterthought. We have the drill we talked about. We're developing and we have an outreach pediatric education and simulation program that is helping our hospitals in the state qualify to become pediatric ready. And we have a recognition program that will enable them to get verified for that. And then we're increasing our community engagement and stop the bleed and home disaster preparedness for schools so that these are places where there's community engagement and the public also understands what the threats are. So our job is not only to convince hospitals that pediatric readiness is important, but that it's both achievable and worthwhile. And I think as surgeons, we need to be part of that team to facilitate bidirectional capabilities and just make sure that children are recognized as an important part of that plan. And at this point, I'm going to turn it over to Dr. Newton. Do you want to show your own slides and I'll stop sharing, or you want me to advance?
Why don't you stop and I'll share my own, and that'll be
right.
Uh-oh. Hey there. Hello. Hey Mary, can you guys see this?
I can see it and I can hear you.
Okay. I'm so sorry. When excuse me, when I shared went in presenter mode, it like just made my entire screen disappear. It really confused me for a moment. I'm so sorry. I'm just going to leave it in this mode if that's all right. Let's see if I can try this one more time. Nope, this doesn't work. That's all right. So if you didn't notice, a lot of Dr. Fallat's discussion began with national and system stuff, and then evolved into what do you do for pediatrics in a disaster on a state level, and hopefully obvious. We're very passionate about systems of care, and because this is how you take care of so many people. So my task now is to take it down to the local level. So you've had national, you've had state, you've had systems. Now you get down to a facility level. What do you do in your own hospital in preparing for kids? So I want to acknowledge that trauma centers are inherently kind of tied to hospital emergency plans. From some trauma directors' perspectives, a mass casualty happens on any random Friday. However, I've seen a lot of institutions where the emergency management program administratively and the ER and the trauma and the perioperative environment are not necessarily synced. And the trauma program may list all the things in disasters that you guys do, but that does not necessarily mean you're engaged in all of that. And so I encourage you to do that, to jump into your emergency management committee and get into the process of preparing a plan for mass casualties of any nature, and integrate your trauma program into it and your perioperative services. So my task for the last few minutes here is to give you a little bit of the pediatric lens. So if you are an adult or general trauma center, you may take care of a mix of an adults and kids, and you're revamping your facility plans. What are the kinds of things that you need to think about for the pediatrics part of your population? And it may not be your entire population, so acknowledge. So first, let me mention the pediatric COEs. Mary mentioned all of these as she was going through the federal programs, and the PPN, of course, the PEDS Pandemic Network that she described is a network of children's hospitals. So that is a hub and spoke, lots of children's hospitals. They are intended to reach out to other community hospitals and other general hospitals and kind of make everybody better with PEDS. That PEDS Pandemic Network is bringing preparedness and disaster planning to the healthcare community. The other end of the spectrum, which started first in 2019, is is the regional concept. So there are 3 regional centers. They are designed to integrate public-private entities to cross state lines. And they are bringing pediatrics to a disaster community, an emergency management community that is sometimes not comfortable with kids or not ready for kids. And so each of these has grown significantly over the past 5 years. They all have projects and tools and guides that that may be specific for their regions, but can be transplanted and replicated kind of wherever you are. So part of the reason of me talking about this is step one in if you're going to think about your facility, where are the good resources, the best practice, the toolkits, the guidelines? So as reference, you can see the URL code there. If you go to that code and look under partners, there is a link to all these websites we're talking about. There's links under partners to all 3 pediatric COEs, to the Peds Pandemic Network, to ASPR Tracy that has lists of everything. I will also note that the AAST Disaster Committee has a web page. It's easy to find on the resources link on the front page of the AAST site, and lists tons of great resources that you can use. Most of this stuff that I'm talking about is pediatric specific. And to give you an example of, okay, that's great. So, what kind of resources? So DMEPS, EDMEPS as an example that came out about a year or so ago. Many of you may be familiar with the in-person DMEP course, which many of us who are trauma directors for many years, took in person, and you had to find and schedule an in-person site. There is now a digital version, so you can go on the American College of Surgeons. You do have to pay for the course, but you know what? It's pretty fantastic. You can do an electronic version, and it actually has great content talking about what do you need to do and what do you need to plan for your facility. And there is a lot of pediatric stuff integrated through that entire training package. New product that's also coming out that will be up on the disaster website soon. It is hot off the press as of this week. It is finally completed. It's a playbook. So this is a templated manual, and you go through the templates, and you can insert your own hospital floor plans for your operative areas, as an example. And then you insert your own hospital floor plans and figure out what do we need to develop for our plan for our hospital. So these are out there. I wanted to show the resources. Please go take a look at them. This is how you get into a lot more depth. Okay, so in talking about PEDS in your disaster plans, every plan is local. Every disaster is local. I can't tell you exactly what you need in your facility. It depends on what the disaster is and what your hospital can do. And so my point here is to tell you about big picture items and things to think about for kids that need to be integrated into your hospital plans. So step one is what's considered a hazard vulnerability analysis. And you need to ask the question, if I am a general facility, what is the impact of kids in my facility if something happens? And you may say, well, it's not that significant until you begin to look at the statistics, and you kind of see the numbers of kids are often involved at a much more profound level than you would think. Yes, kids are 25% of the population, roughly. Not uncommon. There's more kids than adults in any given event. And as Dr. Kuhls will tell you, when a mass event hits your hospital, there's a lot of surprises. And so plan for the kids, think about what's in your area, and you go through this hazard vulnerability analysis process. Your emergency management team will do this annually. They are accustomed to doing this. The trauma team, I encourage you to get involved in that process. It's a discussion of honest evaluation. Where do we have gaps in our facility, and where are we vulnerable, and what kind of disasters might we need to see? And ask yourself when you go through this, what about the kids? Okay. Next bullet point. Big principles of MCI, and this infiltrates all sorts of things, getting into crisis standards of care. The big principle is you take care of as many as you possibly can to the very best of your resource abilities. And so this philosophy, yes, the needs of the many outweigh the needs of the few. The problem when you talk about kids is that philosophy breaks down. So those who don't know, crisis standards of care is your policy, is your rule book for what happens when we need to ration care. How do we implement that? You hopefully in your hospital have this written out somewhere. It is it's a very anxious area to be in to talk about this, and when you get into kids, it becomes problematic. So doing the standard scoring systems, many can't actually implement. And so you need to look at your crisis standards honestly and figure out, how do we stay out of that rationing phase and stay in a contingency phase in our facility? Does that mean that we have partners that we don't normally have? We transfer kids to different facilities, we level load, we do different kinds of care that we wouldn't normally do, simply because we don't want to be in that boat in the first place. All right. Next big principle is triage. So many of you in trauma centers have been through triage discussions before. It's integrated into the ATLS. These are the scenarios where you have an entire field full of pots, and you have to go through and decide, who's first and who's second, and categorize patients into these 4 categories: expectant, minimal, and immediate and delayed. For kids, the kids' curveball to triage is this. There are a PEDS version of the START system. So you have SALT and Jumpstart and systems. The PEDS version of START also teaches a doorway evaluation. So looking at a child from even a distance, you can very quickly look at head, heart, and lungs. Are they breathing? Do they have perfusion? Are they awake and responding? And you can do that for kids very, very quickly. The other difference in triage is it encourages, if they're not breathing, in the adult system, you put them into an expectant category. For a child, it's encouraged, try to fix their airway, because sometimes you can't. So you get rescue breaths, you try to resuscitate them very briefly, and then you categorize them. So slight deviation in the triage protocols. Practical advice that I will give you as you're thinking about your plans for your own hospital: putting children into an expectant category or a minimal category means that they don't get care. For kids, that's really hard. Those are categories that practically don't exist, because the healthcare providers and the parents have an emotional problem accepting those 2 categories, which means triage for children often, speaking honestly, boils down to either right now or wait. And those are kind of the only 2 categories. So think about this as you set up your system. how are you going to get the kids that are waiting into an appropriate, queue for whatever they're waiting for? And you need systems to be able to do that. All right. Next big topic I will mention in all of emergency management, the common vernacular that gets talked about for preparing is space, staff, and stuff. So when you're looking at your facility, those are the three things that you're going to scrutinize. So as you're going through that, yes, you're going to look for kids. Do I have the right ET tubes? Do I have the right size chest tubes? Do I have the right specialists? The space staff stuff is what gives every facility that doesn't take care of kids anxiety. And it's the spot where you can fail and have challenges. This is where that PEDS Ready program that Mary was talking about is intended to impact. So it does not matter if you are Children's Hospital or not. It doesn't matter if you're a rural community or level 1 urban trauma center or level 2 suburban hospital. This is the space, staff, and stuff standards that get you to a competent level for kids. This is why it's a big deal. And it's why it's plugged into now American College of Surgeons verification process. It has been shown if you have this box checked, it'll save some lives. Yes, if you want to make your facility better, do the PEDS Ready checklist. And if you're not at a score of 93, get to a score of 93. That will do more for your disaster plan in your hospital than anything I can give you. All right, next big bullet point. I just mentioned staff. In a disaster, if your staff are not functioning, they're not available, you've got a problem. Staff are by far your most valuable resource in any event. Important to recognize the pediatric perspective I will give for this. All of your staff have their own kids. And if your people in your facility don't know where their family is and they don't know that their family is safe, they're now non-functional. You need to find a way to make sure your staff knows where their family is. Some level of communications, at least an attempt at it. It's a missed aspect in a lot of plans of how do we take care of the children of our own people, because it's important to them. They can't do their job otherwise. All right. When you're working through a facility plan, you will naturally, after you do your HVAs and you're looking at the flow in your hospital, you are going to identify bottlenecks. These are areas, pain points, and areas in your hospital that patients have to flow through, that there's limited resources. Just like your hazard vulnerability analysis, when you get to this point, you need to ask the question, what are the limited resources specifically for kids? Sometimes those limited resources are different than the ones you would normally list for the rest of your general population. Such as, how many designated beds do we have? And can we expand? Do we have the nursing flexibility? What about ventilators? Can radiology fast track kids the same way they do adults? You can go on and on with this, but it's an important consideration as you identify your bottleneck. Ask yourself, does this gap in our hospital, does it act the same for kids as it does for adults? Okay. Inherently, your hospital plan is going to have a pool of volunteers. Happens in every event. There's tons of folks that show up to help. You have call trees for all your staff. They come into the hospital to do things. For PEDS, appreciate the fact in your ancillary support, in the volunteer pool, in the various roles that show up to your hospital, some of those folks are hugely valuable. You will have to deal with kids that may be okay. Maybe the most valuable thing they need is safe and reliable daycare, and because their parents aren't there. Social work, chaplains, staff that are cross-trained that can do any age. These individuals, do not forget about them. Integrate them into your plan, because on the day of disaster, they become pretty critically important. All right. Core issue for pediatrics. When an event occurs, any disaster, any crisis, and the children come, they are usually accompanied by an adult. There is a guardian or a parent, mother or father, and very often that adult is not willing to separate themselves from that child, especially in a big disaster. That means in many communities, we have adult centers and pediatric centers, and they're not necessarily connected to each other. And so each of those respective centers needs to be prepared to care for the entire range of human being. If you have an injured mother and child, contemplate in your plan how you're going to treat them together. You may want to separate them. That may be medically desirable, and there's nothing wrong with that. But you may find on the day of the disaster that you can't, because the parent is just not going to consent to that. You've got to be able to roll with that scenario, and you've got to be able to do the very best you can, treating both of them together. PEDS also presents the other end of the spectrum. So if the child shows up and the parent's not there, and the child can't speak, now you have also a very significant problem. This is why in pediatric disaster planning, you also have to consider patient identification, tracking, and reunification. It also means you may have a population of patients that are uninjured, but you can't discharge. They're now in your custody, and you need to have a place for those kids and a system to connect them between where they are being cared for and wherever their families are. Pulling this off means a written protocol. It means getting social work and clergy and having devoted space for the kids and having a plan for how you reunite the kids after you've verified who's their parent. So great resources on all those sites that I showed about what are the details of a reunification plan. I encourage you. I love the Red Cross. I think they're fantastic, but your plan cannot be, we're just going to call the Red Cross. That's not a plan. You got to look at your facility and figure out how you're going to get over this particular problem. All right, and the last thing that I will mention is that is unique to kids is mental health and resiliency and bouncing back. And sometimes it's hard to identify which kids are kind of at risk for having significant problems, and yet it's really, really common. So most trauma centers have some level of screening for PTSD. When you have mass numbers, not only do you need screening, but you need a way to triage and figure out who's most critical when it comes to mental health needs and who's less so. So there's one of the toolkits. Once again, you can find it in those resource links that I gave, called SciStart. that is focused just on this problem of not just screening, but triaging, and what is the acuity, and can mental health care be provided on an acute level, or in a pediatrician's office, or down the road. And fantastic tool, easy to access, easy to implement, and lots of our hospitals have stood this up, and it seems to be going really, really well. All right. Final comment I will give you is all of your hospitals, I know, do drills and exercises on some cadence. All trauma centers do, all emergency management programs do drills, even if they're tabletops. I encourage you, if you're a trauma center, get involved with your emergency management program enough that you can include the trauma bay and the perioperative suites in your drill planning. And how do you organize the surgical perioperative environment? And then number two, insert, what are you going to do about the kids? And your system may come back and say, well, we don't deal with kids. But that's not honest. In a disaster, you might, and you need to be able to have at least the capability to flex. So think about all these concepts, think about these bullet points, and insert them into your plans, and then run through them, and make sure that you haven't overlooked anything in your local facility, whatever the needs may be. All right, I'm going to stop sharing, and thanks for your flexibility in my screen sharing, because clearly that threw me for a loop, but I think we got through it anyway. Deb, any questions in the QA chat? I'm not sure Mary or I have been able to monitor.
Hi, so I've been monitoring. Let me just check again. There are no questions there, and I've also looked in the chat and I don't see anything there. I would just like to thank both of you for just a wealth of not only experience, but of information, guided by, insurance and your great work to help facilities, all hospitals, trauma centers, and non, prepare in the event of a mass casualty in their region that affects children. And Dr. Newton, I know you made mention of, I heard my name during your talk, and I would say during our Las Vegas shooting in 2017, which was really horrific, and we had some older teenagers, if you will. So we did have some children, but after sort of the dust settled, or the sand has settled in Las Vegas, we actually ask ourselves, what if there were like hundreds of injured children?
Yeah.
Would have we been able to, care for them? And that's one of the motivations for me personally to be involved in pediatric disaster preparedness, and I think others as well. And we really appreciate the sage advice of people like, both of you. So.
No, thanks, Deb. Well, and you bring up an excellent point that I didn't mention in your planning. One of the profound lessons learned in the Las Vegas shooting was transport is often by private auto, and people get in their car and they drive to the closest hospital. And if a parent gets in their car and is driving to the local hospital, they don't know which hospital is a trauma center, and they don't know which one has PEDS capabilities. They're going to go to the first place that their cell phone tells them is a hospital. And if that's you, then you kind of need to be ready for them.
Yes, absolutely. You know, in our shooting, nearly 100 injured patients ended up going to the nearest hospital, which was not a trauma center.
Yep.
So yes, I think we all need to be prepared. And I think the information that you shared is really the voice of experience and a lot of planning. So I really thank you both. Um, it- I know you've talked about websites and so forth to check. Do you want to just say a couple of words where, these types of resources can be found?
Yeah, the URLs that I had in the slide, I don't know if people were able to see them and download it, but the intent was if you go to rapam.org on the front page, you can get to all the resources. There's a spot there that says partners. You can pull it down. You can get to the PPN. You can get to Ask for Tracy, to the other COEs, to your regional partners. So I listed that because it's a gateway to everything else.
Deb,
So I'll just
someone asked
go ahead.
if these resources will be available afterwards. And I think, Caitlin, this was recorded. Am I correct? So it should be available on the website.
Yeah. Yeah, the disaster website, I'm sure we'll be able to put it up on the disaster website. And for those who don't know, the WST is also evolving a pediatrics website that will have open content on and have things like this listed. So that's not live yet, but is coming.
Okay. We also have a question. Can you share the slides after the meeting?
Yes, I'm happy to. And if anybody emails myself or Mary, I'm happy to share.
Yep.
Yes, and Caitlin Sanders, who's one of our staff members from the AAST, indicated that she will be uploading the recording and slides to the website. And in the event that there are people online who are not members of the AAST, you can get to the disaster resource page without signing in. You don't need to be a member of the AAST. And it looks like there are a couple of other questions. So thanking you, sharing the slides, and then with busy EDs who are constantly at capacity, how do we get buy-in to run drills to prepare? We have real patients to treat.
Yeah, it's an excellent question, the good and bad of running a real-time live drill, because obviously there's a downside if you do that, it can impact your patient care, and you can't do that. So many places have solved this problem by doing tabletop-like drills, or drills in which instead of a real patient, you have index cards that travel through the system. Um, uh, these are ways in which you can practice and plan policies and tools and ways that you're going to do stuff, hopefully without interfering with ongoing patient care. I will encourage you, however, there's a few aspects. If you're a trauma center and you're looking at your surge capacity for your OR, if you're planning and drilling in the middle of the night, it's very different than drilling during the day. And what you want to test your system is, can I open 4 rooms in the OR? Most of us can't without canceling elective cases or doing some major problem. So if you're going to set out a policy of this is what we're going to do, practice it as an example in your perioperative area with your nursing leadership and challenge them with a question. All right, you have 10 minutes, open 4 rooms for me. Can you do it?
We also worked as a group on the disaster committee to publish a paper with a checklist for preparing your operating room for a disaster. Catherine Kelly is the first author, spelled Kelley, I believe, but If you take that and do an exercise with your own operating room, that will also show you where the gaps are in surgery for purposes of planning. And we do quarterly simulations, but with real actors, children from the community, but we start at 6:30, so it's a little before the OR starts. But I think you probably have to consider that there's an active OR schedule most days and do it off hours.
Yes, and to sort of build upon that, that theme of be ready all the time is at the end of a busy OR day, many ORs have kind of their their standard equipment waiting to be cleaned by the night crew, if you will. So I think always having enough clean supplies and so forth to open up multiple rooms, I think is important. Now, Caitlin also put the web address for the AAST disaster management site in the chat. And that is, again, you don't need to sign into the AAST or be a member to have access to that. And that has resources for both adult and pediatric patients and some just-in-time training. I don't see any other questions. I would like to thank, our audience for your attention on this important issue, as well as both of our speakers for an outstanding talk. And so again, thank you for tuning in to AAST Grand Rounds. Good afternoon, everyone.